CSF Analysis, presented by Asra, Talat and Tajwer, guided by Dr Manjushree ma'am. Objectives: Introduction, Production, Circulation, Composition, Collection, Physical Examination, Routine Lab Tests, Indication, Diagnosis and Summary. Introduction. Definition: the fluid that surrounds the brain in the skull and the spinal cord in the spinal column, formed in the choroid plexus of the lateral and to some extent in the third ventricle of the brain. Cerebrospinal fluid analysis. Production: approximately 500 ml of CSF is produced each day, that amounts to 0.3 to 0.4 ml per minute. Adult volume 90 to 150 ml. Neonates 10 to 60 ml. Total CSF is replaced in 5 to 7 hours. 70% derived from ultrafiltration of plasma, 30% from ventricular ependymal lining and cerebral subarachnoid space. Showing the pathway where the CSF is circulated. Circulation. CSF leaves the ventricular system through medial and lateral foramina, flows over the brain and spinal cord in the subarachnoid space, reabsorption of arachnoid villi along the superior sagittal sinus. CSF analysis. It is a way of looking for conditions that affect your brain and spine. It is a series of laboratory tests performed on a sample of CSF. Clinical application of CSF examination. In the diagnosis of bacterial, viral or fungal meningitis, encephalitis, malignant infiltrates like in acute leukemia, lymphoma, subarachnoid hemorrhage, spinal canal blockage leading to elevated intracranial tension, subacute sclerosis, panencephalitis. Composition: protein 15 to 45 mg per dl, glucose 50 to 45 mg per dl, urea 6 to 16 mg per dl, uric acid 0.5 to 3 mg per dl, creatinine 0.6 to 1.2 mg per dl, cholesterol 0.2 to 1.6 mg per dl, ammonia 10 to 35 microgram per dl, sodium 135 to 150 micro equivalent per liter, potassium 2.6 to 3 milli equivalent per liter, chloride 115 to 130 milli equivalent per liter, magnesium 2.4 to 3 milli equivalent per liter. Specimen collection. The lumbar puncture needle is inserted between 4th and 5th lumbar vertebrae to a depth of 4.5 cm. The stylet is withdrawn and the fluid flows through the needle. The flowing CSF is collected in 3 tubes. Tube 1, few drops in sterile container. Tube 2, 6 to 7 ml. Tube 3, 3 to 4 ml. Tube 1 is discarded if contains red cells in plenty and tube 2 is used for examination. Correct positioning and effect on the spinal column. Physical examination. Color, colorless, pH 7.28 to 7.32, appearance clear, specific gravity 1.003 to 1.004, note clot formation on standing, total solids 0.85 to 1.70, PO2 40 to 44 mmHg, PCO2 lumbar 44 to 50 mmHg, cisternal 40 to 46 mmHg. Routine lab tests. Opening pressure, macroscopic examination, microscopic examination, glucose and protein. Microscopic. It is the examination of the cells seen in the CSF. Procedure. If CSF is clear, then there is no need of dilution and both RBC and WBC can be counted simultaneously. If CSF is cloudy, then make some dilution. Cells in CSF should be counted immediately without delay to prevent degeneration of cells, which gives false result. Bloody or traumatic tap adds approximately 1 to 2 WBC per 1000 RBCs. Hence, in the estimation of total leukocyte count, a deduction is made equivalent to 1 WBC for every 700 erythrocyte counted. Reference intervals for CSF. Cell type, lymphocyte, in adults 62%, neonate 20%, monocytes 36% and 72%, neutrophils 2% and 3%, histiocyte rare, in neonates 5%, ependymal cells rare in both, eosinophil rare in both. Increased cell conditions. Neutrophil in meningitis, infections, metastatic tumor, lymphocyte in parasitic infections, degenerative disorders, plasma cells, acute viral infection, eosinophil, fungal infection, reaction to foreign material. Glucose examination. CSF glucose is derived from plasma glucose. Hence, ideally CSF glucose level should be compared with fasting plasma glucose level for adequate clinical interpretation. The glucose oxidase method. Glucose oxidase acts on glucose to produce gluconic acid and hydrogen peroxide. Breakdown of hydrogen peroxide by peroxidase is coupled with oxidation of phenol. The oxidized phenol is complexed with 4-amino antipyrine to give red color, which is measured at 530 nanometer. Clinical significance. CSF glucose less than 40 mg per dl or CSF by plasma less than 0.3 are considered abnormal. Normal to be 0.3 to 0.9. Causes for decrease: meningitis, tumors involving the meninges, subarachnoid hemorrhage, cerebral amoebiasis. Increased CSF glucose is of no clinical importance. Protein examination or clot or coagulum formation. Allow the specimen of CSF to stand overnight and examine the sample for fibrin clot, which is formed if the sample contains fibrinogen. Nature of clot, delicate, cobweb-like, is characteristically seen in the tubercular meningitis. Clot may have entrapped tubercle bacilli, which could be tested microscopically by staining for acid-fast bacilli. Coarse clot is formed in pyogenic meningitis, traumatic tap, and in case of complete spinal block. Turbidity method or TCA method. It is based on turbidity, where protein particles on precipitation due to denaturation by TCA lead to scattering of the incident light. The emergent light density is decreased in proportion to the protein content and measured photometrically at 470 nanometer. Diagnosis by CSF. High sensitivity, high specificity is done by bacterial TB and fungal meningitis. High sensitivity, moderate specificity is done in viral meningitis, SAH, CNS syphilis, abscess. Moderate sensitivity, high specificity, meningeal malignancy. Moderate sensitivity, moderate specificity, intracranial hemorrhage, viral encephalitis, subdural hematoma. This is the summary for the presentation. References are taken by V. H. Talib, Clinical Pathology, Concise Clinical Pathology, Henry's Clinical Diagnosis and Management by Laboratory Methods.